this week on the BackTable podcast.
Let's say you have a 25-year-old patient, which is not uncommon, who's had debilitating, painful periods really since menarche, since she started her periods. And she's been told by her pediatrician and by her gynecologist who gets an ultrasound that everything is normal. And they make it sound like, it's all in your head. We just, this is normal. Well, when you do the ultrasound yourself and you see some of the criteria that are consistent with adenomyosis, and I tell them I'm not proving that you have it because I don't have a biopsy. I'm just saying you have changes that are consistent with adenomyosis. Just the relief you see on their face, like, okay, I'm not crazy, really is part of the treatment.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. And welcome back to another episode of BackTable OBGYN. And this is your host, Mark Hoffman. Once again, I've got with me Dr. Amy Park. Amy, how are you?
Good. How are you?
Good. Clinic day, OR day, admin day. What were you up to today?
Yeah, I had meetings all day.
I'm getting used to that. This is my last week of actual full clinical schedule. Next week, it just becomes meetings, mostly meetings. All right. So we have a great guest today. As usual, this is someone I've known for a long time. I think everybody knows Dr. Keith Isaacson, reproductive endocrinology and infertility specialist and minimally invasive gynecologic surgeon at Newton Wellesley Hospital. Clinical director for MIT's Center for Gynepathology Research. He's an associate professor of OBGYN at Harvard Medical School and past president of AAGL, SRS, and the AAGL Fellowship Board. Is that right, Keith?
And that's correct.
Welcome to the show.
Thank you for having me.
Well, like we'd like to do for most of our guests, tell us about yourself, your practice, sort of how you got to be where you are, and what you're up to in your day-to-day.
Sure. I went to undergraduate school at Tulane University, then went to medical school at Emory in Georgia, then did my fellowship in reproductive endocrinology in University of Pennsylvania, and which was heavily focused on reproductive surgery at the time before IVF, and then started my first job at Mass General and Harvard Medical School in 1989. And have been doing that ever since. Starting in 2001, even though I still practice at Mass General and Brigham and Women's Hospital, I moved most of my practice to Newton Wellesley Hospital because we had more opportunities for surgery. And starting in 2004, we began our fellowship for minimally invasive GYN surgery through the AAGL, and that is still going strong. And then from 2009, I started collaborating with Professor Linda Griffith at MIT for the Center for Gynepathology Research to study really the origins of endometriosis and adenomyosis using organ-on-a-chip technology. And so today, I still busy clinically, see patients Mondays and Tuesdays, do a lot of office hysteroscopy procedures. Wednesdays is my research day. Try to spend most of it at MIT when I can. Thursday and Friday are either all-day surgery or surgery plus research. And then Saturday and Sunday, I try to make it to New Orleans to go visit my 2-year-old grandson, at least once a month.
Sounds like a good balance.
Yeah, it's fun. It's fun. Thank you.
So, and maybe later on we can get into since you've discovered the origins of endometriosis, we were talking about that yesterday with my residents, and it's the list of possible causes of endometriosis just keeps growing. But let's start with adenomyosis. What is adenomyosis?
So adenomyosis is the presence of epithelial glands and stroma in the muscle of the uterus. It was a disease up until about, I'd say, 6 or 7 years ago that was thought to affect only women in their late 30s up to menopause, that caused heavy menstrual bleeding, painful periods, possibly painful intercourse. But the reason we thought that it was only women we thought women who were multiparous, who had several children, were at higher risk for developing the disease. It turns out the only reason we thought that is because those were the women who were getting hysterectomies for their pain and heavy bleeding. Certainly if someone's in their 20s and having pain and heavy bleeding, they're not going to have a hysterectomy. So the disease was diagnosed by histology, by taking out the uterus. And we happened to miss the disease in all the women who did not have a hysterectomy. So with the advent of better MRI criteria, now ultrasound criteria to help us diagnose the disease, we realized that adenomyosis is present in women and girls as early as high school age. And it turns out about 15% of girls in high school miss at least 1 to 2 days a month because of heavy or painful periods. And now when you do ultrasound on them, you can see ultrasound evidence of adenomyosis. So it's much more prevalent than we thought it was. It's now, we understand that it affects women, all women in any reproductive age group. And certainly, probably the fact that they had had their children does probably not increase the risk of developing the disease. So everything we thought we knew about adenomyosis 5 years ago turns out to be wrong. So we have to kind of start over. We also know now that it impacts fertility with women with recurrent implantation failure, as well as early miscarriages and possibly even premature deliveries. The most interesting part of this is that 80% of women who have endometriosis present with painful periods, heavy cramping. We always thought that, okay, that's related to stage 1 or stage 2 endometriosis. So you go in, you remove a little lesion on the ovary or the surface of the peritoneum, that's going to improve. But it turns out we just missed the adenomyosis in those patients. So my personal bias is that adenomyosis is probably much more common and certainly presents with more common symptoms than endometriosis does. So we kind of have to rethink everything we thought we knew about endometriosis as well as adenomyosis. But that's kind of where we are today.
Why would it cause infertility? Is it just produce like some bad juju? Can you explain it to me, a non-REI?
Yeah. I don't know about the bad juju part, but there's 2 parts of the myometrium of the uterus. There's the inner myometrium, which is thought to be represented in MRI, as you know, as the junctional zone. And then there's the outer myometrium. They actually have different embryologic origins, where the inner myometrium is Mullerian in origin, and it responds to estrogen and progesterone receptors. It gets thick and thin throughout the cycle, and it has coordinated contractions. So this inner myometrium in their proliferative phase of the cycle actually has these contractions that bring the sperm into the cavity. And in the second half of the cycle, it's either quiescent or it actually contracts to keep like bacteria out of the cavity. So if you disrupt that coordinated contraction, which adenomyosis does, type 2 myomas do, type 3 myomas do, that's one of the theories as to how it might impact infertility and implantation. It's just a theory. There's other theories that there's other juju that's been thrown out there, like the HOX10 gene, the homeopathic genes are also dysregulated in patients with adenomyosis. So at the end of the day, there are a lot of theories as to why that's happening. But I think the data on looking at implantation failures in patients who have genetically screened normal embryos, and even patients who've had donor embryo studies, those with adenomyosis have about a 50% lower rate of implantation and a higher miscarriage rate than those without adenomyosis. So I think the fact that it impacts fertility now is no longer really controversial based on the data. The mechanism is still very, very much unknown.
When you say diagnose, though, like you said earlier, we're diagnosing it historically, pathologically, and that's what I was taught in residency. Now we have a lot of ultrasound reports and MRI reports that are reading adenomyosis. Like, how accurate are ultrasound and MRI in diagnosing adenomyosis?
So the short answer to that question is approximately 80% accurate. So if you look at the studies that were done well by Caterina Exocusos in Italy, Danielle Luciano here in Connecticut. When they actually did the study where they looked at ultrasound criteria and then compared it to their histologic data on hysterectomy, they were able to find it about 80% of the time. That data is actually hard to reproduce. So we've looked at it in our patients. Others have looked at it and find it closer to 40 to 50% of the time. But the key is how many slices the pathologist does. So when Caterina Exocusos did her study, she asked the pathologist to get at least 15 slices of the uterus. A normal uterus will have about 5 or 6 slices. So if you actually do more slices, you'll find it more often. So the fact that it's not on the pathology report is not really an indicator that it's not there. It's just that he didn't ask the pathologist to take enough slices.
It reminds me of like the fallopian tube, and we had the guest come on talking about fallopian tube cancer, and how much of the ovarian cancer that we think of historically, the high-grade epithelial ovarian cancer started in the tubes, and we just didn't really take many slices to even look for pre-malignant lesions. So not that it's not there, it's just that we're maybe not looking for it enough.
Exactly.
So the other thing that is, I think, challenging for a lot of us, though, is that if we have ultrasound or MRI findings suggesting adenomyosis, then what? So, I mean, obviously, infertility treatments can vary state by state. I'm in a state that is very different than Massachusetts, where you are in terms of coverage, but also with symptoms. So let's start with symptoms. How I know how you treat adenomyosis is a little bit different probably than a lot of people treat adenomyosis, but what are kind of the traditional treatment options for adenomyosis for symptoms? And then what are you doing differently in the same question for infertility?
Well, let's go back a little bit just to the diagnosis, because what you'd have is let's say you have a 25-year-old patient, which is not uncommon, who's had debilitating, painful periods really since menarche, since she started her periods. And she's been told by her pediatrician and by her gynecologist who gets an ultrasound that everything is normal. And they make it sound like, it's all in your head. We just, this is normal. Well, when you do the ultrasound yourself and you see some of the criteria that are consistent with adenomyosis, and I tell them I'm not proving that you have it because I don't have a biopsy. I'm just saying you have changes that are consistent with adenomyosis. Just the relief you see on their face, like, okay, I'm not crazy, really is part of the treatment. It's just recognizing there is an explanation to their painful periods, the suffering they've had for the last 10 years, where they were told everything's normal, just suck it up. And my collaborator, Linda Griffith, she had the same issue with adenomyosis, endometriosis. Is a professor at MIT, and they said, look, we'll give you a couch to put in the bathroom. So when you have pain, you can go lay down on the couch. And that was their answer. She also had breast cancer. They gave her 6 months off. She says the adenomyosis was much more debilitating than the breast cancer. So this is what they're dealing with. So I just want to explain that the recognition of it, just the acknowledgement that there is something that can explain their pain is half of the treatment. So the other half of the treatment now is your options are clearly, it's either medical or surgical or do nothing. So medically is the most common, where ideally one of the levonorgestrel IUDs is placed because it's thought that the progestin that's absorbed by the myometrium is going to be suppressive, and it helps if they're not having a period. And the data show that it does help 80% of the time. And the 15 to 20% that have it removed is not necessarily because the symptoms didn't go away, it's just that they didn't like the side effects. So if that doesn't work, then you have to try other types of suppression that may or may not have the side effects. So you may try something like norethindrone, agestin. You may try a progesterone-only birth control pill. But when they take the pill, the key is to do it continuously where they don't get a period, not where they're getting it cyclically. And then the last option is obviously surgical. And surgery, assuming they want to maintain their fertility, is very, very challenging. I don't do it at all for pain or heavy menstrual bleeding, but we will do it for fertility on rare occasion. So if there's a focal lesion in that junctional zone or that inner myometrium, then, and the patient's had a history of recurrent implantation failure, then we'll go ahead and resect that lesion hysteroscopically. The largest series of doing this is out of the Ukraine, and it was 20 patients. And they had good success in 20 patients. That's a pretty small series. And that Ukrainian series was done after the war, so they're still doing it. But that's the largest series. And then there's a series out of Japan where they actually do it by laparotomy, where they resect the whole back wall of the uterus and then do a flap. And that works for fertility, but it also has about a 6% chance of a uterine rupture in pregnancy.
Now, is this like an adenomyoma we're talking about here? Because a lot of times we look at imaging and look at MRIs, and it looks a little more diffuse. There's not necessarily a specific focal lesion. And I've done, a lot of us who do myomectomies will take out a myoma that turns out comes back an adenomyoma, and it just didn't look and feel right, and it's a little squishy. But that's a little bit easier for me to understand as opposed to like more diffuse adenomyosis.
Yeah, I'm not sure there is such a thing as an adenomyoma. So by definition, an adenomyoma is a fibroid that has a pseudocapsule that has glands in it. Okay. I don't see that very often. What I see is you're going in for a fibroid and it's actually just kind of crunchy tissue with no clear plane. And all that is just diffuse adenomyosis in the myometrium. So it's not really a fibroid. It doesn't have a pseudocapsule. So what they're doing by laparotomy typically is just debulking that. You're not removing all of it, but they've had good pregnancy rate success. But again, the risk of the uterine rupture is a little high. So I'm not
How
sure
many were in that series in Japan? Pretty small as well.
No, it was much larger. They've done over 1,000 patients. Yeah.
Talk to us about hysteroscopic surgery for adenomyosis.
Yeah, it has to be a focal lesion. And so you identify it by ultrasound, and then you try to confirm. Then I try to confirm it by MRI. And then when you go in, so then I do ultrasound guidance when I'm doing the resectoscopic procedure. And you go with a bipolar loop electrode with a resectoscope, and you actually shave out the adenomyosis in that area, that's that focal area. It's usually about 1.5 centimeters. Sometimes it's a cyst, which is very easy to see, which is like shelling out an endometrioma. So you actually go into the cyst and it's old blood in it, and you just have to get out the cyst wall. That part is very straightforward. The harder ones is when it actually looks like glands. It looks like that adenomyosis that you saw by laparotomy when you do a myomectomy, but it's just right underneath the endometrium. And you want to resect that until you get to normal myometrium. And you do that with ultrasound guidance. So I've been offering that to patients who have focal adenomyosis. There's select patients that have recurrent implantation failure, but I can't really tell you what the success rate is going to be yet. So my series is no more than 20 as well. So that's just not enough to make the patients really have nothing else. It's either that or they're told to do get a gestational carrier. Well, it's easy to tell somebody that, but it's also somewhere between $250,000 and $500,000. So it's not available to a lot of people.
I didn't realize it was that expensive. That's incredible. So ultrasound guidance, you're using abdominal ultrasound or transvaginal? I know you reproductive endocrinologists will sometimes use use ultrasound for IVF and things like that. So normally I would use abdominal ultrasound for something like that. But
you kind of have to use abdominal ultrasound for guidance during surgery. So you haven't filled the bladder, bring in a transabdominal ultrasound probe, and then it's helpful to see about, particularly if you know where you're looking ahead of time, based on MRI and transvaginal ultrasound, you know a pretty good idea where you're going to be going. But you don't want to resect you want to resect as little endometrium as possible so you get the best guidance you can. So that's why I use all three.
Are you giving them any estrogen or anything afterwards to protect the lining, to prevent Asherman's, things like that?
No. If they have normal estrogen levels, and this is true in patients with Asherman's as well, adding more estrogen doesn't help. The only time to give estrogen is when they're hypoestrogenic, breastfeeding or something like that. But no, there's no reason to give supplemental. And the beauty is, it's like a submucous myoma. If you're only resecting on one wall, you tend not to get Asherman's. The only time you get the Asherman's with myomectomies is when you're resecting two opposing myomas. So
Yeah. I've heard some opponents of global endometrial ablation for that reason, that if you do hemiablation and just use the old roller ball and do half, your chance of getting an Asherman's is so much lower because you don't have two burned sides opposing the other. And it sounds like it's kind of the same theory.
That's exactly right. Plus, you don't want to resect too much endometrium. You want to keep it focal rather than into the patient. Because the other alternative for treating this in patients trying to get pregnant is 2 to 3 months of a GnRH agonist prior to a frozen transfer. So the data is pretty good that your embryo implantation rate is about 50% of what you would expect if they have adenomyosis in the inner myometrium. If you pre-treat with a GnRH agonist for 2 to 3 months, and then you go through the frozen embryo transfer protocol, you'll get your implantation rate back to normal. So let's say it's normally 30%, 15% without treatment, you treat them and it's back to 30%. So again, the ones that I do surgery are the ones who failed that as well. So I always try the medical treatment first. The only time I do the surgery is when their next step is they were told to have a gestational carrier. So I feel like we have nothing to lose, because I don't think it's a risky surgery. I do think it just helps that if you're facile with a resectoscope, because the tissue shavers won't work for this. But if you're pretty good with a resectoscope, it's pretty straightforward.
Talk to us about endometriosis and adenomyosis. I mean, I know with your lab, maybe you can go into a little bit more detail about what y'all have learned or what y'all are finding and sort of the relationship between endometriosis and adenomyosis.
Yeah, the lab focus is really a little different, and that is, as you're aware, with endometriosis and adenomyosis, there's no good animal model, okay, because it's the only animals that get spontaneous endometriosis are the monkeys, and it's almost impossible to study monkeys. There were a couple chimpanzee populations, one in Kenya, one locally in the past, but they're just too expensive. You just can't do it anymore. So all the other animal models looked at rabbits and rodents, and that this endometriosis was kind of falsely created surgically, but these are not animals that cycle on a monthly basis. So the validity of those animal models is probably very little. So the whole idea was, what Professor Griffith has done in the past, she's a tissue engineering person. So she grew the first human ear actually in a mouse that was just transplanted out to a human. She's grown bladder, she's grown bowel. Now she's trying to grow liver. So I went to her in 2009 and I said, can you grow a peritoneal surface so that we can study endometriosis? And can you grow a uterus so we can study adenomyosis? So that's kind of where we are with this. This technology is developed, instead of growing whole organs like you would an ear or bowel or bladder, it's all done on an organ on a chip, which is organoid models. So now these organoid models they're working, they're being perfused with oxygen and blood. And now we're at the point where you can add and subtract various cytokines and monocytes and inflammatory factors to really just study the behavior. So even though I'd love to say we were further along to understand the disease, we're trying to build the model so that we can understand the disease. Because I truly think our goal here is not to really overwhelm women hormonally who are suffering from endometriosis and adenomyosis. If this is truly an inflammatory disease, then there should be some pathway in the inflammation that you could interrupt that's going to treat the disease without suppressing them, without putting on megadose progestins, all the horrible things that they have to go through. So that's the goal of the research. And we're just about at the point now we're going to start testing some inflammatory inhibitors to see how it works in the model. So that's where we are. So it's really exciting work, but is it going to be clinically useful in the next 5 years? Probably not, but it's going to help. Because if you think back on it, Mark, I mean, you're not as old as me, but we haven't progressed in the last 30 years in this disease. We're still treating with continuous pill. I think our understanding of who suffers from endometriosis and adenomyosis is better than it was 30 years ago. But as far as treatment, it's identical. It hasn't changed. I don't think surgery is the answer. And currently, hormonal suppression is not the answer. So,
do you feel the same way about endometriosis?
Absolutely. Even more so with endometriosis, yeah.
We had this conversation at our resident gynecology conference, and the longer I've done this, the less I think surgery is the answer. And I love AGL, and it's afforded me many of my professional opportunities. But a lot of the folks there are so focused on the surgical treatment, and to me, it's a microscopic disease. And I've talked about this on the show a number of times. But reading The Emperor of All Maladies and understanding how those early surgeons were just cutting more and more away until they understood, like, hey, this may be at the cellular level. This is not something that we can cure with a knife. And the longer I've done this, the more I think we're chipping away at like an infection as opposed to actually treating the cause.
Do you think that the White House initiative to put more funding into women's health research will help? I mean, it's been woefully underfunded. I think NICHD has, now a program officer who's now the gynecologic branch chief who's interested in fibroids and endometriosis. I mean, it seems way more promising, quite frankly, for complex gynecologic surgery conditions than urogynecology in a way, to be honest, looking at the way things are going. But I agree about the medications. Like, it just seems like Mirena, OCPs, I mean, how come we can't have some sort of immune modulator? I mean,
you have to understand the pathway, and that's what we're trying to do. So that pathway has not been worked out. So you have to understand the pathway before you can interrupt it. And then that's the goal of these models, is to try to do that. But your point about funding is so huge. So yeah, we were clearly, Jill Biden was here last week or 2 weeks ago for that, to kind of promote that new funding opportunity. We'll see if they put their money where their mouth is, because we've heard this before. If you have breast cancer, ovarian cancer, anything with organ cancer, and you're going to get huge funding. But they look at endometriosis, fibroids as benign conditions, and they don't fund them where they're not benign. They are incredibly disruptive and malignant. They may not be metastatic, but they're malignant. So I hear that they're going to go with this new funding and new initiative for women's health. We hope you're right, but so far the funding has been horrible. But also the publications. If you look at, I think it's Linda Griffith shows a slide where in the last 5 years there's been over 2,000 publications on Viagra, and there's been less than 300 on adenomyosis. So it's just, they go where the money is. I don't know.
Well, when the people voting for where the money goes are primarily interested in Viagra for personal reasons based on what's important to them personally, yeah, it is. And that's been the hardest thing for me lately, is when patients ask me, what we can do, and the answer is we don't know enough. Here's what we know. I wish we could tell you more, but there's just not enough information. And I'm grateful that you guys are working on an aspect of it.
There are things we can do. So I think we can work with our pediatricians. We can work with the primary care docs. That here's the things that are normal and not normal. If you have a patient who's in high school, is missing school, send her to an adolescent gynecologist who's aware of possible adenomyosis. Teach the gynecologists how to do the ultrasounds themselves, because the radiologists don't know how to do this. It's not being taught. So they don't know the MUSA criteria. They're not aware of picking up adenomyosis by MRI if it's not a thickened junctional zone. So we have a lot of work to do just making people aware, and that's stuff we can do now, and we should be doing now. And I think that'll go a long way.
But you see adenomyosis and endometriosis as the same disease spectrum?
No, I think people confused. I think they ignored. I think 95% of women who present with dysmenorrhea have adenomyosis. Because how is just tell me physiologically how a spot of endometriosis on your bladder is going to cause painful period. Cramping period. How does that happen? How does a spot of endometriosis on your bowel cause, dyspareunia? It just doesn't make sense. So the only reason we accepted that is because you did a laparoscopy and you couldn't see adenomyosis, right? It's in the muscle. So if you can't see it, it must not be there. But that's just not the case. Now you can see changes that are consistent with it, and it makes a big difference. If you look at all the papers and said, okay, how come women with stage 1 and stage 2 endometriosis got better after surgery? Look at the papers. Every single one of them, after surgery, they were put on hormonal suppression. Everyone. And so if you do surgery and then you put them on hormonal suppression, you should get better. Now do the same paper without putting them on hormonal suppression and see what happens. But I don't think ethically you could do that.
Yeah, I'm also surprised like how many hysterectomies I do for prolapse, and then it feels like adenomyosis. It's so soft, and then pathology does not reflect it. And then I do these hysterectomies for adenomyosis, and the pathology doesn't reflect it either. Like, to your point about this, how many slices they're doing or what have you. I mean, I've had that happen with the tubes as well, where I had a patient, I took out her tubes, and then a year later she was diagnosed with, or 2 years later, she had ovarian cancer. And then they went back and looked at the tubes, and it was like, oh, it was there. Just kidding.
Yeah.
Some FMSIN was there. And I don't know if like that's something more slices or AI or something could help with diagnosing that, but it
doesn't change the management at that point. The only time it's going to be helpful to do that is for research purposes, and then you tell them to slice more and they'll find more, but it doesn't change what you're going to do.
But finding the true prevalence of the disease, I think, like you said before, is very valuable and powerful to say, like, look, in people who have these symptoms, if you look hard enough, most of them will have some pathological evidence of an abnormality, right? I mean, that's something that...
Yes and no. So we got to be careful here too, because I object to gynecologists, and a lot of them are doing this, who say, okay, by MRI and by ultrasound, you have adenomyosis. Well, you don't have a pathology to prove it. So really the proper thing to tell a patient is you have changes that are consistent with it. I don't have a biopsy. I think it's there based on your symptoms, which is another reason why the gynecologist needs to do the ultrasound, because you're the one who knows the symptoms, so you know what to look for. But I still don't have a biopsy to prove it. Is it necessary to get a biopsy? It'd be great. And there's a study from Belgium where they used a spirotoned to try to go in and get a biopsy hysteroscopically into the area where the ultrasound was abnormal. Again, it's only going to be done for research purposes because it really doesn't change your management. You're going to treat the symptom, not necessarily the fact that it's there. So I think it'd be wonderful to know the true prevalence, but I don't know how important it is, as long as by ultrasound we can show the changes and then act accordingly. But I don't want to overcall it. So I'm biased, so pretty much everybody in my practice has adenomyosis until proven otherwise. So I have to be careful not to overcall it. All the patients who come in with heavy bleeding, but all those patients who we did endometrial ablations on, that was the interesting thing. It was contraindicated if they had adenomyosis. It was also contraindicated if they had a submucous myoma. Those are the only two things that cause any bleeding. So the only patients getting the ablations were adenomyosis patients. So thank goodness we don't do many of those anymore either.
Yeah, I mean, certainly in my practice, there's a lot of people who are sent to see me because they failed, or they didn't fail. The procedure failed them, but they have persistent symptoms. And you guess what I'm trying to say when I say we want to understand the prevalence, not to make the diagnosis in everyone, but the same way when I have somebody who comes in with painful periods or pain with intercourse, we, like you said, telling them it's not normal. I can't diagnose endometriosis without surgery. Does that mean I need to do surgery to treat you with continuous OCPs or norethindrone? No, because if I do the surgery and find it, the treatment's going to be the same. If I do the surgery and don't find it, maybe you have adenomyosis and the treatment's going to be the same. So unless we're actively going in there to do something, if you feel better without surgery, is there a need for surgery in that particular patient at that point? And I think there's some debate on that topic.
Right. But I I think if it's dysmenorrhea, which again is the primary complaint for 80% of the patients with endometriosis, then a Mirena makes more sense than a continuous pill to me. So I kind of encourage them to go that route as opposed to a pill. And some will accept it and some won't. And so that's how, at least seeing the ultrasound evidence or the MRI evidence changes my practice a little bit. And then the ones that I reserve for laparoscopy are the ones that have bowel symptoms, bladder symptoms, things that are clearly at least symptomatologically, whatever, is outside the uterus.
So it sounds like that it's so interesting because I'm not, I'm sort of adjacent to the field, but it's like pre-op diagnosis, still challenging. No blood tests or anything. It's imaging. Pregnancy, those patients who are desiring fertility or uterine preservation, treatment is still challenging. Pathophysiology, we still don't know. And I do have to say, when I do a hysterectomy for the adeno patient, they are really satisfied. They're like the happiest patients once they're done. But it's just so interesting to me that nothing has changed. Like, why? The funding, the imaging has gotten better, I will say, like for the ultrasound and the MRI, and MRI has gotten cheaper and it's a little easier to get covered. But like we've talked a lot this show about like what's the best patient-centric options. And we're sort of not having a lot of options. It feels so bleak.
Well, I don't disagree, but I think we're going in the right direction. If we get funding, that's even going to be better. But I go back to where we were in 1972 and Buttram. I don't know if you guys know V.C. Buttram, but he was a kind of a pioneer mixed surgeon, reproductive endocrinologist out of Houston. And in 1972, he wrote a book. And in his book, I always give this in my lectures, he said, endometriosis is a disease of upper class white women who have a desire to excel. They're kind of high maintenance women.
Wow.
Wait a minute. No, he says they dress impeccably and they're demanding. Okay. That's what he said. Those are the patients at risk for endometriosis in 1972. What was the reason for that? Because they're the only ones that got laparoscopy. So it wasn't available to everyone. It was the upper class white women who demanded it. And that's kind of where we are with adenomyosis, well, at least maybe 5 years ago, and that we were so wrong as far as who it impacts, only because we're making the diagnosis by hysterectomy. So I do think in the last 5 years, just to look as your glasses half full instead of half empty, we've made a lot of progress. And I think I'm hoping in the future we'll have meetings on, that aren't called endometriosis meetings, are called adenomyosis meetings, because I think it has a much greater impact on a woman's life than the actual stage 4, stage 2 endometriosis. So
let me just ask also about, endo. I know there's this whole crosstalk, visceral cross-sensitization. Do you see that as much with adenomyosis? I don't know. It doesn't seem as prevalent, but I was just wondering.
Crosstalk in what way?
Like Ashley Goebbels is here, and she's our pelvic pain specialist, and she always talks about the bladder and bowel crosstalk and how, there's a lot of syndromes that overlap. And it doesn't seem like the adenomyosis does that as much, but I don't know, because you guys are seeing them more.
I think it does. And this is what my collaborator, Linda Griffith, is. She's passionate about. She's convinced that a lot of women who are presenting with this irritable bowel syndrome, particularly any bowel symptoms, they get worse with your period, may be related to the inflammation that's right in the uterus, which is right adjacent to it. So we don't have any proof of it, but I do think there is a camp that agrees 100% that there's crosstalk, particularly between the bowel and the adenomyosis.
Is it just a central sensitization, or we don't know? Same nerves?
I don't know.
Supplying,
it's again the thing to follow when you do the hysterectomy for adenomyosis. A lot of the bowel symptoms go away. So I don't know the mechanism.
And then when I talk to patients about interstitial cystitis or IBS and endo, we know they're commonly co-diagnosed, and treating one oftentimes makes the other better. Like you said, we can give birth control pills, and a lot of times their bowel symptoms get better, their bladder symptoms get better. It's these chronic pelvic inflammatory conditions with no known cause. But clearly, just the neighbors are pissed off. If one person's inflamed and angry, the other, the neighbors aren't going to be too thrilled either.
Yeah.
I mean, I don't know.
The difference is endometriosis. You can get a histologic diagnosis. You can't get that with irritable bowel, and I'm not sure you can really get it with interstitial cystitis. So that's somewhat debatable. So, those two are a little more subjective versus objective, but the endometriosis, at least you can document. But I agree. I think at the end of the day, I think it's going to be an inflammatory condition on all of them, but the inflammation pathway, believe it or not, just hasn't been worked out with endometriosis and adenomyosis. So
I've read a few articles about the microbiome, the reproductive microbiome. We've had people come on the show and talk about the urinary tract microbiome and why people thought urine was sterile, and like obviously there's talk there, and that was one of the questions I asked, and I think he said, what about the reproductive microbiome? Why do we think that's sterile? Why would it be sterile? I mean, there's the sperm gets up there. There's obviously a connection between the vagina and the pelvic cavity, right? The peritoneal cavity, because otherwise there'd be no reproduction. So there's some early studies about certain bacteria that are more prevalent in women with endometriosis, and also could potentially explain the adenomyosis. It's all inside the uterus too. Do you think there's any connection there, or do you what are your thoughts on that?
It's not the way I like to do science. So microbiome is now a research tool. So what we're doing is, let's take that research tool and apply it to a condition and see if we can find a connection. And the way I would prefer the science be done is, let's come up with a hypothesis, which bacteria or how the microbiome could actually cause endometriosis or impact adenomyosis, and then look for it. And so it's the same problem. The reason we didn't get anywhere in the last 20 years for endometriosis wasn't because we weren't looking at inflammatory cytokines or monokines, but everybody had their favorite one. So they would say, okay, my lab focuses on, IL-6. So I'm going to look at IL-6 and endometriosis and come up with a hypothesis. That's not the right way. You're not going to get anywhere in science if you do it research that way. You need to come up with a hypothesis first that's, has some scientific basis to it. Then if you use your research tools to either confirm or deny that hypothesis. So I don't know if I'm making sense, but that's how I see the microbiome right now. I haven't seen anyone come up with a real hypothesis. They say, there's a research tool, let's just throw it at endometriosis and see what comes out. I'm not a fan of that approach personally. Hopefully I'm wrong and they'll find something.
No, I appreciate your input. I mean, that's why we like having guests like you on the show, because I'm not a scientist. This is stuff that, to me, I think a lot of us out there that are doing this work, that are taking care of patients that, like we said, don't have the answers, we're very glad there's people like you out there that are doing the science, that are trying to figure this out in a way that can result in an answer.
So we hope it works.
What are the other big labs around the country doing? Like, what are the other directions people are taking that are interesting to you?
It's a great question. May rest in peace. Rob Taylor had a great lab going. He's just passed away about a month and a half ago. I know Hugh Taylor's doing some work in Yale, looking at kind of different approaches to this. They're doing good work. Fasiliabas and Michigan State. So there are some good labs looking at this. So they're all different approaches. But at least, again, the approach that I hope people will do is, let's deconstruct the lesion so we can understand it first. And then as we reconstruct it, we can look for therapeutics that'll kind of interfere with the process.
It's fascinating. It is. No,
that's my life. There you go. You got it. That and flying.
Still flying.
Still flying.
Do you fly yourself down to New Orleans?
I do. No, I have a dog I fly with.
Can you get there nonstop?
I can get back nonstop. I usually have to make one stop going there because of the headwinds.
One of these days.
I'll stop in Kentucky. I'll look at the fuel prices. There you go.
The races are going to start soon in April. Keeneland's a great time to be in Lexington. It's a fun weekend. Come anytime. All right. Well, thanks so much, Amy. Anything else?
Yeah, thank you so much. I love hearing. I'm just a curious person, so I just love hearing your perspective, and I'm actually really heartened by the fact that you and Dr. Griffiths are collaborating, because I think that's where the richness of the clinical and the basic science research and the translational research and really elucidating the pathways that's where the breakthroughs are going to come through.
There's a really nice article about her, right? Was that what paper was that in? Was it the Globe or was it the New York Times? Yeah. If you've not read it, Amy, it's awesome.
But just the collaboration is unique, and that's why I feel lucky to kind of be in this area, because I go there just given the clinical problem, and then I'm like surrounded by all these geniuses, and I understand about 25% of what they're saying, but I learn something every time I go. And we're just doing this amazing, 3D histology work on adenomyosis and this label-free 3-photon imaging of adenomyosis using the laser. It's just phenomenal. It's fun to watch. I'm just telling you.
I mean, I have no idea what you just said, but it sounds very cool.
I'll show you some pictures, but it's fun to watch.
That's great. That's great. Well, it's always a pleasure catching up.
Thanks, guys.
Good to see you, and thanks again for your time, and thanks for joining us.
All right, take care, guys.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and Digital Marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.